Good afternoon. Thanks for staying so long. So we are going also to talk about EIT, but focusing on perfusion. Just a brief comment after the talk of Belani. We have, just for your information, we have recently finished this protocol in where we assessed EIT distribution of ventilation in patients with acute respiratory failure after cardiac surgery. And when we detected an improvement in the distribution of ventilation like this, something that was suggested by Jacopo, and then we had an improved compliance in the bottom part of the lung, a little bit of overdistension. The final result, as published in this paper of JAMA, was decreased length of stay. So in some specific situations, it's very clear that this device can guide us to have a better lung status. So, but the aim of this presentation is to talk about lung perfusion. Lung perfusion is something that we have been looking for a long time with EIT. At this point, we propose that we do an apnea to measure perfusion, and then we inject a bolus of saline in the right atrium. This is required because of technical reasons, but we are already conceiving a protocol to measure perfusion during tidal ventilation. And then at this point, you can measure ventilation, and then at this, measuring this drop pixel by pixel, this perturbation caused by the saline solution, you can measure perfusion. It's the principle that we use here is the same that we use for CT or MRI to measure perfusion. You inject a contrast and you check in the image the perturbation. The regions suffering the largest perturbations are the ones receiving larger perfusion, like this one. Okay, this is the basic principle. And then obviously there is lots of mathematical calculations behind, but you can have by this procedure a map of perfusion at the same time that you have a measurement of ventilation. This is the bolus of saline going through the heart, pulmonary hilum, both lungs, and then back to the left atrium. So you can see this online, and then you can get a number for this, because then you can calculate pixel by pixel, and this was explained in this paper published in Journal Applied Physiology. Nowadays, to separate the cardiac phase to the lung phase, we have a special procedure that then gives us the map of perfusion just in red and separating from the heart phase. In some validation studies, we compared CT perfusion, which you need lots of radiation and lots of contrast and a very fast machine, with EIT. And in this particular study, we are occluding pulmonary vessels with a Swan-Ganz catheter. And then, for instance, if we occlude here with a Swan-Ganz, we can see a defect of perfusion in the left lung, also in EIT. If we occlude the right lower lobe, we can also see a defect on EIT. So this feasibility study was very reassuring. And we have applied in the clinical practice. I like very much to describe this clinical case, and we have accumulated lots of clinical cases. This is a patient with a pulmonary mass scheduled to have surgery to remove the tumor. But then the patient got suddenly hypoxemic and then had to enter the ICU to stabilize before going to the operating theater. And then there was a big doubt in mind. So is this sudden deterioration of the patient caused because we had more obstruction of the left bronchi, or this sudden deterioration was caused by some occlusion of pulmonary vessels? And this had different consequences for the surgeon, because he was, if this was a vascular problem, he was proposing to remove the whole right lung. And, something that caught our attention is that there was some hyperinflation in this left lung. And then we did a kind of disconnection maneuver from the ventilator. And when we disconnected the ventilator, we observed that this lung deflated while the right lung was compressed by the left lung and inflated. So, well, maybe this lung was overinflated. And this was clearly the case. When we reconnected the patient, we could see that there was auto-PEEP building up, and this lung was squeezed to the right side. But then when we analyzed the perfusion, wow, this was very surprising. So completely bilateral perfusion. And in fact, we had more perfusion in the right lung. So clearly, there was no pulmonary vessel occlusion. And how we explain the sudden hypoxemia of the patient? This was the ventilation map. This is the perfusion map. And then you can see that the hyperinflation associated with a lot of perfusion of this lung caused hypoxemia. So this was a clear case of a VQ mismatch. And then we said to the surgeon, okay, you can just remove the lung, the tumor, and then you are going to remove the occlusion here in the left bronchi, and then the case was solved and the patient went very well. In some other cases like this, the patient had a severe pneumonia, was very septic, but for the surprise of everyone, there was no hypoxemia. The patient was under 21% oxygen. And then everyone was a little bit surprised about this, and then a little bit in doubt that if this was really a pneumonia. And then we did a ventilation map, clearly showing that there was a big defect here. But when we did the perfusion map, look at this. Heart, there is no perfusion in the right lung. So the patient had a tumor and a pulmonary emboli to the right lung, and then he was saved by this because he didn't have any flow to the pneumonia region. So he had, in fact, a pulmonary emboli, and then this changed a little bit the approach to the case. So having this possibility at the bedside has been very helpful. And this is also another intriguing case because this patient had a recurrent pulmonary emboli. And then when we measure the perfusion map, we could see a big defect in the right lower lobe. And the ventilation was perfect. And then, this patient went to echocardiography and had a huge pulmonary hypertension. And then there was this suspicion that he had chronic emboli. But he had no history of episodes of dyspnea. But anyway, then we did arteriography, and this was the case. It's interesting because after removing these clots, and now there is a very invasive surgery to do this, look what happened. We did a perfusion scan right after, perfusion EIT study, right after removing these clots, and this is the final result. Complete reversal. I had to agree with the surgeons that sometimes this surgery works. And this was an amazing case. So from 30% to 41%. The patient gets dead for 40 minutes. It's a terrible surgery, but it works. And in this particular case, it saved the life. Also, some physiological studies that are giving lots of insights. This is an interesting study in which we enter the bronchi, we occlude the left lower lobe, and then we check the behavior of this occlusion under two conditions of oxygen fraction, 50% and 100%. So this occlusion caused completely blockage of the ventilation in the lower lobe, but at 50% net nitrogen stabilized the alveoli. When we use 100% oxygen, there was complete reabsorption atelectasis, which you can see here. After the occlusion, you see a decrease in the size of the left lobe, which we don't see at 50%. So clear occlusion. But this is an interesting situation because we can be sure that after this occlusion, we have complete hypoxemia in those alveoli, right? So let's see what happened with the perfusion. So this is 50%. Remember, you have hypoxemia in those alveoli. You cannot see here because you have nitrogen stabilizing, something that at 100% you can really perceive. But then look at the perfusion signal. A big decrease from 47 to 38. This is hypoxic pulmonary vasoconstriction. And what happened at 100%? Even further. And then this is something that we are learning, that sometimes it's not only the hypoxia that it's important, but also the squeezing of the vessels by atelectasis itself can further compress and impair the blood flow. So then when you keep the size of the lung, sometimes hypoxic vasoconstriction is not perfect. Something interesting is that we tried to assess this by CT perfusion. And at first, when we measured this, we got this bright signal here in the atelectatic zone, and then we said, wow, maybe this is an artifact of EIT. But then we realized that there is a big difference here. CT is measuring a thin slice, and EIT is measuring a thick slice. So, in fact, we are measuring with EIT the perfusion of the whole left lung. So, in fact, to have an equivalent distribution, we had to compute the tissue density in this region, and when we computed this, now we have the same signal as EIT. So, because, in fact, EIT is representing the lung perfusion to the left lung, and then only after normalizing by the densities that you can have the same results. So it's not easy to compare different techniques. Also, some other experiments about pulmonary perfusion that are very interesting, and we are getting some insights on this, is, for instance, this patient with bilateral ventilation, and then you have bilateral perfusion. The animal is normal. But then we have a blockage of ventilation. And look, this animal, in fact, had a huge pulmonary hypertension and very good hypoxic pulmonary vasoconstriction. And the proof of this is that oxygenation was very well preserved. But then we gave a little bit of dobutamine, and then you can see the difference. No dobutamine and dobutamine. Why? Because dobutamine just increased pulmonary artery pressure, and this forced the passage of blood through the lung, even with hypoxic pulmonary vasoconstriction. So we are doing this all the time at the bedside, and we cannot observe this. And you can see here clearly superposing both images that you have a very large shunt. And it's interesting to see those movies, because then you see the size of this reflex. This is bilateral ventilation, bilateral perfusion. Now we have blockage of right lung ventilation. Very good hypoxic pulmonary vasoconstriction. And now we are going to give dobutamine. Big difference, huh? It's very beautiful to see these at the bedside. Finally, I have a very interesting case that is an experiment that we are doing. I have 1 or 2 minutes. It's an animal that we are doing ECMO, testing some physiological concepts. So we have bilateral ventilation, bilateral perfusion. Okay, this is the ventilation map superposed, so you don't see too much areas of shunt. But now we have one lung ventilation simulating a very severe pneumonia. Okay, and then this is the ventilation. So, and the animal had a very good hypoxic pulmonary vasoconstriction. But then we switched on the ECMO device. And now what is happening now is that blood rich in oxygen is reaching the pulmonary vessels. We had the hypothesis that this would impair pulmonary vasoconstriction, and let's see what happened. This was exactly the case. So not only dobutamine, but giving a flow like ECMO, a flow of blood reaching oxygen can relieve pulmonary vasoconstriction. And this is explain why some patients, after switching on ECMO, they are very hard to remove it. You have to wait a little bit till there is accommodation of this reflex. Okay, so finally, the last subject is that EIT also allows you to study perfusion using the pulsatility. Pulsatility is just the bulging of the stroke volume in the pulmonary vessels. And then if you synchronize with the ECG, you can see this kind of image that we are getting at the bedside now, and you can see the ventricle area, and the blood is squeezed to both lungs during this systolic movement. And this can be easily seen, for instance, in patients. So you can observe at the same time ventilation, and then you can analyze the perfusion. Why this is important? Because there is a very interesting publication now showing that you can automatically separate the heart area and the lung area. And then they are in opposition of phase because the stroke volume is squeezed from the heart and reaching the lung. Then if you focus in only one of these areas and you calculate this amplitude, this is proportional to the stroke volume. And this is exactly what we did in patients. I'm going to skip this. And I ask you to read this paper because then we have shown that by tracking these oscillations, you can track changes in stroke volume in a large range of situations at the bedside. For instance, these animals, they had some bleeding, and then we refueled the volemia with volume, with a saline. And this is the stroke volume measured directly from the heart, and this is the EIT signal. It's almost complete superposition. So we believe that these new features of EIT, they are going to be very helpful at the bedside in the future. And in fact, it's available already, but we need more validation studies to check the situations in which we can use at the bedside. Thank you very much.
Thank you so much. Outstanding. Any question, Laurent?
Thank you very much, Marcelo. This is really exciting. I have two questions. The first one is, in most of the first slides, you just show the distribution, like percentage. So no quantification in each zone. Is it something which can be changed in the future?
Yes, you are absolutely right. We are very good in distribution, not very good in absolute numbers, okay. But it's something that we are working on.
And I'm just puzzled by the last part of your presentation. You're showing a continuous measurement. Is that
yeah? This is continuous measurement.
So what you have a continuous perfusion of
because
hypertonic saline? Or?
This is a very good question. It's because when we measure these variations, it's very good to have this, to have some estimation of the stroke volume, but sometimes variations in the stroke volume. But to get absolute numbers, we realize that this depends on the elasticity of the vessels. And then, so to get absolute numbers, we prefer to use the saline. This is the only reason. But to get relative distributions, it's okay.
You're using ANT clinically. Do you see a lot of side effects?
Hypertonic saline, we are injecting 10 mLs. In fact, we are decreasing this amount to 5 mLs of 10 or 20% sodium. When you give hypertonic, let's say for brain injury, the total amount is, let's say, 100 times more. The only problem is that it's very fast. And we are collecting data to check safety of this procedure. We never had a side effect in animals, but obviously in human, we need more data. And we are collecting this. We cannot say that it's absolutely safe at this point. We have observed that there is a slight increase in stroke volume during the injection of saline. But this is a well-described reflex. That's it.
Thank you.
Any further question? Yes, please.
Yes, I also have one more question about the saline injection. Is it?
Sorry, about
the saline injection. So you use the saline injection in the patients already?
Yes, yes.
Okay. And
We have accumulated more than 200 patients now.
yeah. And then there's one thing about the VQ maps you showed, like the ventilation to perfusion and the shunting which you wanted to show. I think there's a problem with that because the ventilation and the perfusion themselves, they have a different kind of, well, during the EIT reconstruction, they get reconstructed in a different way because we have positive and negative impedance changes. So we could maybe get a shift between ventilation and perfusion. So we might observe shunt where there's no shunt and ventilation where there's, or dead space where there is no dead space. So what kind of reconstruction are you using to prevent this?
I think the major problem is something that Laurent was mentioning, is that with EIT, we have a very good distribution, but not very good absolute numbers. And then, but if you have, for instance, if you have an overall number for minute ventilation and an overall number for cardiac output, you can get the final absolute numbers. Regarding the reconstruction artifacts, obviously because of the low spatial resolution of EIT, we have some border effect always in the EIT images, but we are learning in the last years which are the regions that you can be very confident. For instance, if you analyze the whole VQ distribution in the lower part of the lung and not going too close to the border, you have very reliable signals. Just one slide. And there is also something that is very promising in the future, which is this. We are using some anatomical data to have an anatomical atlas, and then having more, let's say, reasonable models of the lung. And this is the new images that you can get when you don't have too much spatial filters. You are just using the anatomical atlas to regularize the image. So I believe that with this approach, we can get rid of these border effects that we still have with EIT. But this is something still for the future. What we observed is that even with these constraints of spatial resolution, you know, at the bedside, we are so much missing information that it's already useful.
Okay, thank you.